Welcome to the ASN Kidney Week podcast, exploring the latest advancements, research, and innovations shaping the future of kidney care. Tune in for expert conversations, clinical insights, and highlights from ASN Kidney Week 2024, a go-to source for staying informed and inspired.
Thank you for inviting us all to speak today. My name is Monnie Wasse. I am an interventional nephrologist in Chicago at Rush University Medical Center, and I'm the division chief there of nephrology, as well as the interim chair of the Department of Medicine. And I always enjoyed coming to ASN. This is, I think, my 24th year coming to ASN. I started as a first-year fellow, and we'll be getting into, I guess, a few of the things that we found to be really fun and exciting about this meeting, but I'm really delighted to be here.
Well, again, thank you for the invitation to talk on today's podcast. I'm Edwina Brown. I work in London, England. My main interest is peritoneal dialysis and also the outcomes of older people with advanced kidney disease and conservative care. Again, I've been to the ASN for many years. I also want to focus on my other role as the immediate past president of the International Society for Peritoneal Dialysis and the co-chair for the International Home Dialysis Consortium.
My name is Timothy Ray. I'm a nephrology nurse practitioner in Cleveland, Ohio, in private practice there. I mainly work acute care in the hospitals. I also do some work in local LTACs and nursing homes and things like that, but I predominantly just do acute care in the hospital. This is my third time at ASN over a number of years, in part because I'm also focused on going to other conferences that are more nursing-based as well, and NKF and things like that. I always love to come back. It's a joy to be here and meet everybody and see friends and really be challenged and learn about all the new innovative things that are out there and what we can take back for practice.
Okay. So one of the things that I always enjoy the most is the poster sessions. And I do dialysis vascular access, which tends to be a little bit of a smaller section here. But the thing that I love doing is I get there right at 10 and start going through the posters, and I'm hopeful that whoever the trainees are that are standing there in front of them, and then inquiring about what the content is of their poster. And today I did that and had some really positive interactions. My favorite interaction was with a medical student who is not sure he's going to go into nephrology, but he presented on a particular catheter case that, even with my level of experience and one of my friends who was along with me, that I dragged along with me, neither of us had actually seen a case like this. So we got weirdly enthusiastic about it in front of the student, but I think it was a really fun interaction. So I just love that. That's my favorite thing, because I remember what it was like to be that person as a trainee, and then as a fellow, and then as a junior attending. And there's nothing worse than standing there by yourself with nobody coming and asking you questions, and you've done all this work and you've had the honor of being chosen, and yet there's no interaction. So I really, really enjoy that. That was my favorite part of today.
I was the moderator for the poster session earlier today, and it was really exciting to see the enthusiasm, and people were they were nervous but also really excited. And some of the posters that were presented were just out there and things that I don't fully understand, but there were some things that were really pertinent to what I do in the hospital. Especially one thing that was just like, oh my gosh, that is so cool. I'm going to take that back and talk to my group about it and say, hey, this is something, it's just an idea, but it seems like it might work, and maybe we could think about this. And just the enthusiasm that people have. And again, same type of thing. As I get older, I'm less enthusiastic have the energy. But to people that come here for the first time and they feel so honored and proud of what they've done and want to share it, it's really captivating.
I mean, the ASN is one of the few societies that still has people standing by the posters. Too many conferences have these electronic boards, and you feel really sorry for the juniors who have put in all the time and work to produce these posters, and nobody comes and talks to them.
Exactly.
So yesterday, unfortunately, I haven't been able to get to any poster sessions, which is really frustrating, because I've been involved with 2 symposia over the poster times, but I did make sure that I stood by the poster that my own research fellow had produced, but unfortunately couldn't be here because she's making wedding plans, and which was about transplantation in older people. And so I stood there from about 9:45, so giving me time to get to the session I was chairing. And somebody came by, I don't know who it was, but he came with 6 fellows coming after him. And he made me talk about the poster and then get the fellows to ask me questions. And I thought that was fantastic. It's a good way of educating and really involving your juniors in what's new. And we discussed how would you work up people, older people, for transplants, which is really very relevant to dialysis, particularly as we're now treating so many older people. So I want to ask you about vascular access in older people, because this is one of the downsides, I always think, of hemodialysis in older people, and we have a big sort of discussion with our surgeons about should we be putting in central lines or should we be doing complex fistulas.
Yeah. So there's a lot of discussion about this, particularly with the most recent 2019 KDOQI guidelines. And the prevailing thought prior to that was fistula first at any cost. And we've seen over the last decade and a half, that has posed a lot of problems, particularly for elderly patients, both because maturation can be significantly slower, but also because sometimes patients get these preemptively and then really never go on to receive dialysis. And then as an interventionalist, you're stuck kind of managing these, and can be very morbid for patients. So I think the prevailing view now is that if a patient has sufficient vasculature, has an anticipated lifespan that's something beyond 1 year or so, and doesn't have any truly glaring risk factors for non-maturation, such as peripheral arterial disease, tobacco history, uncontrolled diabetes, and so on, that surgeons, should consider placing an AV fistula in these individuals. Certainly, however, if lifespans are curtailed, or if people are opting to do a home modality, or if other factors come into play, such as lack of family support and so on, different options exist, particularly those for an AV graft. So I think at this point, as an interventionalist, many of us would say that it's ideal to get something that has less of a risk profile for infection in elderly patients, and so we'd still try and avoid a catheter unless there were circumstances like hypotension and things like that. And we would strive to get an AV graft into individuals that aren't fistula candidates.
And from a nursing perspective, how do you feel patients view this?
So I really approach it as that if a patient is looking like they're going to be needing dialysis, I'll talk about the different modalities and options down the road early on, so they have time to think about it and talk to their family. And then we'll even do some vein mapping just to see what the veins are like, because if their veins are so bad that it's not even, the fistulas are not even going to be an option, then we can think about, okay, do we do a graft as it comes closer to dialysis, or do we do a catheter? But that helps provide some information to us so that we don't have to, if they're not an option for a fistula, then we don't have to even go down that pathway. But talking to them early enough so that they can talk to the family, think about it, because it's a big decision for them, which would they want to go, and then which modality. If they want to go peritoneal, I know some of the patients, sometimes I try to encourage that, because it's really a wonderful option for so many people, in which case we probably would hold off on the fistula, but still protect that arm. so that if the PD either doesn't work out or it fails, we've protected that arm down the road.
Yeah, I find that, I totally agree with you, and I find that it helps to add a couple of sentences about the fact that the discussion of vascular access does not mean that you will start dialysis tomorrow.
Correct.
And in many
Absolutely.
cases, people feel like, it's the final straw before they have to initiate dialysis, and it's very difficult to accept that in many cases. And so addressing that up front, I think, can be very helpful for patients. They have some time to think it over, they can discuss it with their family, get more education, but even putting a fistula in a patient doesn't mean that I'm going to tell you you have to start dialysis, imminently.
Yeah.
So.
We even have wristbands, the Save the Vein wristbands that people will wear so that it reminds them where if they go get blood work or something like that, so that it does protect that arm down the road. It just helps give them options in the future.
Yeah.
So I find that many of our advanced kidney care nurses are actually now sending the older and not necessarily the more frail, but definitely the more frail patients for peritoneal dialysis, because many of them prefer to have dialysis at home. Mm-hmm. And also they feel that you need to be fairly fit for the rigors of hemodialysis. And I find that, some people who are choosing to say that they don't want dialysis is they don't want hemodialysis, but when you can offer them peritoneal dialysis, and in the UK, we're very lucky, we have assisted peritoneal dialysis, means that we can dialyse older people at home without, the need for complex transport, without the feeling of exhaustion that you get on dialysis.
So when you say assisted, is it somebody from the dialysis organization that comes out and does this, a trained nurse or a tech that comes in there and does this?
It's a non-healthcare person.
Okay.
So it's somebody, we mostly get the assistants, or we call them technicians to give them a bit of status, through a national healthcare agency, and which is then paid by the renal department, and they're trained how to do peritoneal dialysis. So they will go into people's homes, do usually for 1 or 2 visits a day, so they can put people onto a cycler, take them off a cycler. They may just prepare the cycler and the patient or the family do connections and disconnections, and then they're not quite so tied to the arrival of the technician. Sometimes for the really old and frail people, we will do just CAPD, 2 exchanges, 5 or 6 days a week, because they've still got residual kidney function.
Right. That's maybe all they need.
And we know that in older people, the residual kidney function declines really very slowly.
Right.
And we give them the option. At 3 months, we have a conversation about, do you want to continue dialysis? So you can do a trial of dialysis because they're not losing residual kidney function like you do on hemodialysis. Right. But I actually find that most of them say their energy levels are much better. They're eating better, and they quite enjoy the visits of the technicians,
yes,
particularly
I'm sure
if they're
it's a social event.
It's a social event,
yeah.
and they do very well on it.
Yeah.
So it's akin to having like a home health aide that comes
Right.
and helps with
Right.
dialysis.
That's right.
How much of a difference do you think that makes in terms of their people's acceptance and ability to go on peritoneal dialysis?
Immense, because
Yeah,
these people
has
would
to be.
not be able to do dialysis on their own. Some people have got family members. We have a lot of first-generation people who come mostly from South Asia, and they live in multi-generation families. And the family member is often very happy and, in fact, wants to do the peritoneal dialysis. But then if the spouse, if that's who's doing it, may become ill, or they want a break, or if often it's the daughter, because that's culturally what happens, and the daughter gets married and moves out, we don't then have to put that person onto in-center hemodialysis. We can provide assisted peritoneal dialysis.
It's interesting. The topic was to talk about innovations, and I think just the whole healthcare system in the U.S. versus other places, like in England, in the UK, that the cost of hemodialysis versus home PD is so much less expensive, at least in the United States, and that would be a good, because that's a barrier sometimes for people.
Yeah.
If they don't have somebody else to help them, if they live alone, things like that, we immediately say, well, you can't do it if they don't have that ability. And I think if we think about innovations and trying to promote home therapies a lot more, it might get to the point where that would be an option that, then the question comes down, who's going to pay for it? I mean, if the insurance companies or Medicare or whatever would say, listen, it's still cheaper to have somebody come in to help versus having them go on hemo, that might be an option down the road for people.
Well, I mean, there's a group in British Columbia who've just published their data, which shows that assisted PD is definitely cheaper than
that's
PD
great.
in extended living places and in centre hemodialysis.
That's wonderful.
Obviously, there's no data in the US.
I know for living in an area that we get a lot of snow in the winter, people hate to actually have to go out and travel to and from a dialysis center. So home is a wonderful option for them.
Yeah, and they don't even have to come up to the centre because we have community nurse who will go and visit them at home, do their blood tests.
Right.
And then we can send a Teams link to the nurse, so I can be sitting in my clinic and the nurse is in the patient's home, and it's like me doing a home visit. So it works really well.
That's wonderful.
Yeah, I mean, and the other thing, of course, is I don't know what it's like in the US, but in many parts of the world, and the UK included, there's a nursing shortage. And this is really very difficult for hemodialysis, which is really very heavily dependent on nurses. So in the UK, the nursing ratio is about 1 to 4 or 5 patients. For PD, it's 1 to 20, and in some countries, it's 1 to 50.
Right.
So you need many less nurses for PD than you do for hemodialysis.
Yeah.
And I think this is something that we as a medical community is going to have to address over the coming years.
Yeah. Would you, so since we're all in the program committee and we all worked to try and put our sessions together, Dr. Brown, I'm curious, do you find, given the importance of peritoneal dialysis and the benefits of peritoneal dialysis in our patients, do you find that we're doing a decent job representing PD at the ASN meeting?
I think the answer is certainly this year, given that I was on the program committee. So there are some PD, but also last year there used to be almost nothing, but it has certainly changed over the last recent time. So yes, and it's certainly much better than the European Renal Association, which tends to put any session on PD at the end of the day in the furthest away room, where there's a sort of minimal sized audience.
Yeah.
As with anything, things like that will be slow to change. So as long as we keep promoting it and talking about it, and as society becomes so they accept it more, I think we'll see more and more of it. Would be wonderful.
And I think the other thing that we've done this year is the trouble with dedicated PD sessions. Yes, you do need some because PD doctors need education and want to hear the latest things. You're going to get the converted. But at least what I've been able to succeed doing this time is getting a talk about home dialysis or PD in other sessions. And that means you can talk to people who would not go to a PD session.
Right.
And they can hear about the merits of home dialysis.
Right.
Yeah, that's important.
Absolutely.
We haven't been so successful at doing that with the rest of dialysis vascular access, but certainly it's a great way to really capture an audience and have it the importance of integrating it into the entirety of a patient's decision making and what causes them to be healthful as possible during the dialysis period.
Maybe next year we could devise a session on dialysis access and include both vascular access
PD
and PD access.
Yeah, that'd be a good idea.
That'd be great.
Or if we just talk about it as renal replacement therapy, because then it covers everything, and you can say, it's all the different options that are available. And from a nursing standpoint, I also think about, especially in the elderly, or if they're really sick, one of the options is not dialysis in the end of life issues, which is the best option for some people. Some people don't want to be on dialysis at all. They want to be hooked up in a machine and kept alive. But it's to give everybody those kind of options, and I encourage them to talk to their families and think through this and talk about the risks and benefits. And dialysis doesn't fix everything. You're still going to be 88 years old. You're still going to have all the other things, but it might allow you to get to your granddaughter's wedding or something else that you really want to live towards.
So that's the whole point about goal-directed care.
Yeah.
So which
Quality
is
of life.
something that the ISPD, or the International Society for Peritoneal Dialysis, has really promoted for PD practices, that it's to be delivered so that somebody can get to their granddaughter's wedding. Or I've just been looking after an 83-year-old man with slowly progressive cognitive decline, and his daughter wanted to get him and his wife to Paris for their 60th wedding anniversary, to the restaurant where they had their wedding reception.
Oh, wow.
And we kept going on his PD, despite the fact that he was getting really quite nasty exit site infections and needed a catheter exchange, but wasn't fit enough for a catheter exchange. But we continued the PD. She got both her parents in wheelchairs on the Eurostar to Paris, came back, and we stopped the PD. And he died at home.
That's wonderful.
And that's what dialysis is all about. It's not, as I tell patients and families, we're not offering immortality. We're enabling people to have as good a life as they can and to achieve their goals with a really very problematic long-term condition.
That's a really great story.
Yeah,
That's a really beautiful story. We should consider next year, since we're all on the program committee again next year, since we have international attendance, in many of my society meetings that deal with vascular access, we have a discussion on how things are managed differently in various countries, and I think having a discussion around how do things work in Japan or China or in Australia or the UK, and how do those discussions go around palliative care at the end of life, or transitioning patients to some form of either PD or hemo, but really individualizing their therapy to accommodate the things that they want to achieve.
So we did do a session yesterday on PD, what can be learnt from PD outside the US. And we had myself talking about assisted PD, somebody else from Austria talking about different PD fluids which are not available in the US. Somebody else from the UK talking about the international comparisons in PDOPs, and somebody from Canada talking about more use of CAPD, because not everybody wants to be on a machine. But yet the almost 90% of people on PD in the US are on APD using a cycler. And when I talk to patients, they don't want a cycler at home.
They don't want to be tethered.
No. And they're frightened of a machine.
Yes.
They lose that fear later on if they really need to switch, if they've lost residual kidney function.
Yeah, I think that when I think back, I've been doing this 25, 26 years, and when we first started, really, depending what your EGFR was, you were on dialysis or not. It was a number rather than looking at the patient. And now it's transitioned much more about symptomatology and quality of life, and people have EGFRs 7 and 8%, but they feel fine, they're doing great. So we don't push it as much, but we do a lot of preparation so that they can finally make a decision when that time does come. But to have it, I think it's much more realistic now to life, and I'm thankful for that.
So I want to ask you both a question, and that is about hemodiafiltration. We don't want it all to be about peritoneal dialysis, even though I love talking about it. So in many of the European or other country meetings I've been to over the last year, there's been a big push for hemodiafiltration. But there's really almost nothing about it here in the US. So what's the position and what's the feeling about hemodiafiltration?
So I can't give you the data on that because I'm not aware of all of the data on that, but I do know that some of the factors that come into play are, is there truly an advantage, and is your motivation to truly provide significant filtration or fluid removal when you're dialyzing somebody off of a traditional kind of intermittent dialysis schedule? I think we always have to rely on both the individuals who are trained in a hospital to provide hemodiafiltration, and I don't know if you're speaking specifically of outpatient dialysis, but I'm naming inpatient dialysis. And so oftentimes that can be highly variable in terms of the training. You don't always have a dialysis nurse that's there to provide that. Oftentimes if they hook the patient up, it's either the ICU nurse or the critical care nurse that's responsible for then carrying it out. And I think it can be challenging to teach people a variety of different pathways for dialysis, and so we tend to stick to one until something is truly proven to be more beneficial. I think it can be challenging to find a group of individuals that are going to change significantly. What's your experience where you are, and what are some of the benefits that you have seen people employ or state that causes them to implement this?
So the big advantage seems to be a lower incidence of intradialytic hypotension.
Yeah.
And therefore improved patient well-being. Although it's called the CONVINCE study, there are many who are unconvinced, and it's certainly been very heavily pushed by industry. And the patients, as in many randomized controlled trials, it was a very selected group of patients who get into the trial, and they don't necessarily represent real-life patients. But certainly in my own unit, we do a bit of hemodiafiltration, but not very much. And there is, of course, a cost implementation.
I think the biggest factor that I can see in my patient population, which is more inner city, we have a lot of patients that even getting them in the chair, even having them, you can have all this wonderful things set up, all these studies, and say we're going to do this to this, but if they don't follow their fluid restriction and they don't follow their diet, they come in 6 and 7, 8 liters overloaded, and so to try and even get something off, ultrafiltrate them enough to get fluid off so they can breathe, they do cramp up and things like that. And it's the education of trying to explain to them what they're doing to their bodies. And some of them don't care, which is very frustrating. Some of them don't understand. There's a big psychological, psychosocial aspect to this. And so we can have all these great ideas and studies, but it really comes down to if the patient understands and follows through with what you're trying to do with your dialysis regimen. That's going to be a big factor.
So do you have a big multi-professional team for your, easy, good access to dietitians and psychologists? And
I think we, unfortunately, we used to have a better, years ago we had multiple dietitians, some psychosocial people that were social workers able to help out, and the team was bigger and more pronounced so that you could support some of these people. It just is with cutbacks and healthcare premium, and also post-COVID, there's not as many nurses and team members. We don't have that as much. And that's in the hospital as well as out of the hospital, unfortunately.
Yeah, you mentioned psychologists. We have no psychologists. We're lucky.
Nor do I.
Yeah, we're lucky if we have we no longer have a social worker that's dedicated to the unit. The social worker tends to go to several dialysis units, as well as the dietitian. So oftentimes when you're there to do your rounds, they're not there. And thinking back as to what things were like maybe 10 years ago or 15 years ago, on your day that you rounded at the unit, I would round as a team. So I was with the social worker and the dietitian, and we would go around in a little pack, and it was great because you could emphasize, you had to message things one time, and it would be right in front of the patient. And those days are now over. Right. So it makes it challenging, and I think conversations with patients have to happen over and over because you don't really have the same level of team approach that had been possible in the past.
So is this driven by the chains, or is this that the personnel doesn't exist?
I think it's driven by cost.
Yeah.
Cost.
Yeah,
Yeah.
and what the large dialysis organizations are willing to spend on their personnel.
Right.
That's what it boils down to.
It also comes down to post-COVID, just trying to find the staff, even if they're offering extra benefits and bonuses and things like that. There's less trained people now than there used to be, I think, as a pool, not to mention the number of patients, dialysis patients, is continuing to grow.
Yeah.
And so there's more people we have to take care of with less personnel, and that's part of it as well.
Thanks for tuning in to the ASN Kidney Week podcast. Stay connected for more updates, insights, and expert discussions on the future of kidney care. Be sure to follow us on social media to help create a world without kidney diseases.